Hello?
Hello.
Hi. We're here. Do you hear us?
Yeah, I hear you. Can you
Okay.
hear me?
Yeah, we hear you. Actually, we actually have a conference room with a really sophisticated conference phone, so we'll see if this makes major leaps forward. There's a small group here today, and Dr. Weitzner is here, and I'm here, and what I thought we would do is start out with each of us making some brief statement on the subject of the nature of medications in relationship to orgonomy in terms of treatment, not so much an orgonomic understanding of medication as much as how medication functions in treatment or not, or looking at the issue or raising the issue. So I figured we could each make a brief statement and then take questions, and then I would possibly sum up. How does that sound?
Okay, that sounds fine.
Good. How are you hearing us well?
I hear you fairly well.
Okay, we're hearing you very well. So
Okay.
you feel you're actually for the first time you're a real voice presence, anyways. Okay.
Okay.
I think possibly I'd like to make the opening statement, and then I'll turn it over to Eric Weitzner, and then to you. Okay, out there. All right. When I started really thinking about this, and we all talked about it. Of course, Dr. Weitzner has a lot of experience working with medication, having been both a psychiatrist, but been involved in residence training out at Downstate and working with medications professionally. But certainly, I and Dr. Schiff have had patients on medication, or we've used medication in treatment, or dealt with it in treatment. And so what really occurred to me is there's been ongoing dialogue or controversy for years with people interested in Reich's work or Orgonomy about the issue of medication and whether it interferes with treatment or whether it's something that is counterproductive. But when you really begin to look at it, there's very, very little available on the subject, and there's very, very little certainly from a scientific or empirical basis. Most of it's anecdotal. And the first thing I thought of is that the obvious assumption is that we were going to have this discussion. It was going to be about psychiatric medication or psychotropic, psychoactive drugs. And I was actually not thinking about it in only those terms. I was much more interested in the subject of medication or substances and the impact on the energetic function of the organism in general, whether it's an antibiotic or an antidepressant. In some ways, Dr. Sobey always used to say, it's a substance that you're ingesting into your body. It's going to have an impact. Just as sugar, if you take enough sugar, it's going to have an impact. These are all kinds of things, and that I think one of the primary issues about this from an orgonomic perspective is that we have to start really looking at the fundamental issue of Reich's, I think, central discovery or central model, which is the energetic or pulsatory function of the organism. And so that I think mechanistic medicine or science tends to look at the use of medication as a particular cause, a particular substance introduced and a particular effect. So if somebody's feeling a particular mood disorder, you give them a particular medication, it changes the mood or affects overall functioning. And that's not to be dismissed, but I think from an orgonomic perspective, the real issue is the fundamental pulsatory nature of the organism. If Reich was correct, and the issue is fundamentally biological or physical, and we're talking about the core function of the organism, which is pulsation, expansion and contraction in a healthy or relatively healthy environmental interaction. Then the issue is what either enhances or damages the nature of that function. And clearly, all sorts of substances can impact on that function at any time. Eat too much cream cheese, and as I watch people eat cream cheese, it could impact on your function. But certainly, when I began to look at the literature, whether it was Reich's own writing, which I cover fairly extensively, and then Dr. Schiff did some research on looking at it, and I've asked a few other people to look at it. The fact is, there is virtually no references, and very, very few references in Reich to the use or the impact of medication in any respect, except in anecdotal accounts and except in personal view. The first, I think, most important starting point is that certainly when Reich was coming onto the scene, there were very few active medications. A good deal of his career was spent before there were even antibiotics. Aspirin was relatively new. So the use of medications as a primary intervention were somewhat, if to say the least, limited. To my knowledge, so then it becomes mostly anecdotal, and I think in conversations that I think Dr. Weitzner and I and others had with Dr. Sobey over the years, and I think that I've had with Dr. Rothenberg when he was alive, and Dr. Schiff can comment on this, that it was never my sense what Sobey communicated to me, that Reich had any very, very strong or extremely negative feelings about the use of medication. What appears to be his point was always, what he wanted to know is not whether a medication does X, Y, or Z experientially, but what impact it had on the overall function of the organism. Now, most doctors or patients want to know, like, well, I got this pain, does it make it go away? Or I got this problem, does it make it better? So that in the anecdotal exchanges that I've had access to, and the little bit of personal letter writing or journal writing that Reich talks about these things, he finds substances of various types interesting, but asks a question that I think most people in the psychopharmacological arena or in pharmacology in general don't ask, which is, what is the impact of the substance on the overall pulsatory function of the organism? Does it enhance function, or does it deter or cause some sort of limitation on the function? And to assume that limitation is in and of itself bad is not necessarily what he's saying. He's saying you just have to know what it does, and you have to keep that separate from what your long-term goals are in terms of doing treatment. What I think is unique about orgonomy is always that our goal, whether we achieve it or not, is always a very specific goal, which is to enhance pulsatory function and to help establish optimal access to a healthy orgasmic pulsation. Okay. Now that doesn't mean that failure to do that or failure to achieve that goal is a failure in and of itself. I think it varies widely given various organisms and various levels of treatment. In that context, medications can be used effectively, I think, to weather storms, to get through periods of dysfunction or extreme pain and suffering. In that kind of context, anecdotally, there are accounts which some of you have heard from Sobey, but I think worth at least putting on the record, which is there's what Michael Rothenberg used to call orgonomaniacs, who really believe that no medications, nothing. If you're dying in pain, you got to find out first what your mother did to you to cause you to suffer that way. Okay. As Dr. Sobey loved to tell the account of a patient who I actually know, the actual patient, so it is not just a told story. It's having a severe headache. A patient who had been actually a patient of Dr. Silvert's, one of Reich's associates. He was quite an extremist by all accounts. And he was out of town, so the patient went to see Dr. Sobey with this because he had had a headache for a couple of days. And the patient, so we said, take some aspirin. So the patient said, what do you mean? Dr. Silver would never let me take aspirin. He said, take some aspirin. So he took some aspirin. Silver came back, was furious, and confronted Sobey, saying, this is unacceptable. You should never prescribe any kind of medication. We're having a meeting with Dr. Reich. You're going to be, And they went to Reich, and Sobey smiled and said, and Reich yelled at Silver and told him never to bother him with such stupidity again. He said, the guy had a headache. Dr. Sobey did just right. You give him aspirin, you get rid of the headache, and then you worry about what the possible biological or overall implications are. Similarly, there are numerous accounts, of the fact that essentially you do not want to assume that medications are not useful. The question is whether you go to the other extreme, it seems to me, which is what I think traditional mechanistic medicine goes, which is, you got a pain, you hit it with a chemical, and if the pain goes away, the problem is gone. Dr. Weitzner might take a different view on that, but I'm not of the view that that's really the case. And certainly in my own experience in doing treatment, patients who have been on antidepressants, or anti-anxiety drugs can do well and can function, and it helps. And with some patients, it's all that we have, and orgonomy and nothing else is going to do the trick. But in fact, medications alone do not simply resolve the issues, and very often the treatment is what finally turns the trick. And I've had many patients who eventually stopped using medication and have done quite well. But medications are always an option, always usable, if we understand them not as end-alls and be-alls in themselves, but as part of our relative range of tools or possible options in the course of treatment. And I think they have to be monitored and managed. And I think that's also the case. I have many patients who I've treated who have come to me with chronic respiratory ailments going on, every year, having severe bouts of bronchitis or even pneumonia, and going on long courses of antibiotics. And with successful treatment, that often begins to be less and less necessary. But that certainly wouldn't mean that you don't use an antibiotic when they're getting an infection, if it's used appropriately. So I think that's, to me, a crucial issue here. The next question is the fact that we don't have a real database produced by research. So one of the things I was hoping at least to open up, or at least put on the record here, was the need to build a communication among people like ourselves who are interested in orgonomy continuing in some vital role, and looking at the issue of medication and the use of medication and contemporary breakthroughs in neuroscience, as we've had discussions here on that subject too, and how these play. We don't have the value of Reich being here any longer to say this is what the neuroscientific discoveries or the psychopharmacological discoveries mean, to my work. So I think it's incumbent upon us who are interested in this to begin to look at these new breakthroughs and discoveries in light of orgonomic science. And I don't think they're in any way anathema to it or in any way contradictory to Reich's work. I think they just have to be, in many ways, I think they really validate and enhance a lot of what Reich was attempting to put together and attempting to organize and have much more limited access to in terms of the amount of detailed information that was available. So I think that the idea of setting up a dialogue and a context in which we can begin to look at these issues is vital. Dr. Schiff mentioned getting a communication from one of the younger orgonomists who I know of in Germany, in Frankfurt, and particularly there's a very strong group of younger physicians and people involved with Reich's work fairly actively, and a greater context evidently for doing research and more support for it publicly. And there, again, there was an expression of a desire to begin to look at these issues in terms of how and what you can can do in the context of Reich's work. So that's, in a sense, what I'm interested in. As I said, for me, there's no question about the fact that medications can be of value, but that they are not in and of themselves a magical solution, which unfortunately I think most of the medical community and the general community at large is beginning to discover, despite the success of Pfizer's, economics, but I think there's a lot more that can be done in this, and I think for me the understanding of medication from an orgonomic perspective is vital. And I think the biggest question is that we're not able to really look at, except in specific cases, and we can make reference to some case studies as the conversation extends itself. It's hard to look at actual pulsatory function without medication versus pulsatory function on medication. The data is basically very anecdotal. It's basically look at someone and say, well, this person's functioning this way before medications, they're functioning this way with medication. I'd like to see laboratory work done to even look at the impact of medications on basic, cellular development in simple one-celled organisms. I mean, I'd like to see what happens to amoebas when, Prozac is introduced into the petri dish.
They're much happier right now.
Maybe, I don't know. It would be very interesting. But again, I mean, it seems to me there's a lot of work that could be done. The problem is, and there I'll end my little spiel here, is what Dr. Rothenberg said a number of years ago when he was talking about the problems with Reich's cancer work, is that as a group of individuals who were interested in what Reich introduced into the public arena of knowledge, we have since Reich's death, really, since the end of Reich's work, there's no real research, no really extended full-scale research, and we don't have the means of carrying on that kind of active research economically or in terms of human power, human number of people to be involved in, both from the perspective of people to experiment with as well as people to work on the projects. So we're severely limited in terms of what kind of studies. What I tried to do is to look at the contemporary literature outside of and follow the contemporary scientific developments outside of orgonomy and try to view it from an orgonomic or translate it through an orgonomic perspective. But again, this is somewhat limited. So that's my opening remarks. This is Dr. Eric Weitzner, for those of you who don't know him.
Well, I can tell you in advance that I'm not going to say anything which is going to be very divergent from what Harry said. I mean, we've worked together for a long time, collaborated together. I as the prescriber of medication, and he is the orgone therapist.
Just let me quickly to set something straight. Dr. Weitzner and I studied with Dr. Sobey, along with Dr. Schwartz and a couple of other people who came and went, but we were the primary three that worked fairly continuously with Dr. Sobey. And Dr. Weitzner, since Dr. Schwartz was going to be here but couldn't get the flight that he needed up from Palm Beach, poor man. Basically, Dr. Eric has done my medication consultation, so we have collaborated in one sense, interestingly, so that we've had some sense of how this interfaces when it's been necessary. Unlike some orgonomists, I have Dr. Sobey felt the same. I have no compunctions when necessary using, or recommending the use of medication if used effectively. So I just want to set that stage. So
my approach to this question would be to try to look at the two different sides of it, the practical, clinical side and the theoretical side. I don't think you can really separate them. When I started thinking about this question, I came to the conclusion that this is not an easy question to answer. What is the role, if any, of medication and orgone therapy? Now, why is it not an easy question? Well, if you just look at the field of psychiatry as it's understood by mechanistic biology and traditional medicine, we don't really know how medications work. The field of neuroscience is still maybe not in its infancy, but certainly in its childhood. And the neuroscientists are just beginning to figure out exactly what happens on a cellular level when you administer these medications. Now, when you, as a psychiatrist, when you use medication, you become convinced that something is happening. I mean, this is not just a hype. It is also a hype.
Well, I think as a patient, when you take a medication, you also know something is happening. So, I mean, I think there is a basic reality that something's happening.
Right. Well, there's also, there also is such a thing as a placebo response, and the placebo response to antidepressants in major depression is quite high. It's about 30%. So, you could try a placebo before trying the real thing. But, when you practice psychiatry, you become convinced that something is really happening. Why? Because there's a certain number of cases where the response is dramatic. Whether it's, somebody with periodic, very deep major depressions, what we used to call melancholia. I mean, the response to antidepressants, and it doesn't matter which antidepressant it is just very, very dramatic. When Prozac first came into use, some of the responses that I saw and which you read about in books listening to Prozac, the things that he described are real, and I think they used to happen with the older generations of antidepressants too. But because Prozac was so widely used, it started happening more. And it's true that you do see a certain number of miracle responses. I don't know how else to describe it. Very dramatic responses. People who've been chronically depressed all their lives. People, who have been emotionally unstable and unable to tolerate being alone, and suddenly they change. And it's not that they're a different person. It's not that their character changes, I don't think. I think that something changes in their organism, which is very real. So, if Reich were alive, I'm quite sure that he would not downplay the reality of a reaction to psychotropic medication in cases where the person was suffering. On the contrary, I think he'd be interested in it. He'd want to know what's the explanation for this. How does this happen? And we don't know, because we don't really know on a cellular level, on a neuroanatomical level, exactly what happens. And so what you have is a public which is hungry for easy cures and easy explanations. You have a pharmaceutical industry which is hungry for profits. And you have scientists who are hungry for grants. And so they start making hypotheses which lead to grants, profits, and public satisfaction. So you have, you've had over the years a number of hypotheses, and real scientists know that these hypotheses are only working hypotheses. The trouble is that they're taken much too seriously, like the idea that schizophrenia is caused by, not enough dopamine, or depression used to be caused by too little norepinephrine, now it's too little serotonin. So, nobody really understands why the antidepressants work. So that's one problem. The other problem is if you broaden your view from the narrow mechanistic approach of neurobiology and you try to look at it from Reich's functional point of view, I don't know about you, but I find myself in trouble because, as Reich himself understood, it's very difficult for the average person to understand functional thinking, or to think functionally. And that's why it's so attractive to us to have, mechanistic hypotheses where you can imagine the billiard balls, the tiny electrons or whatever they are. And I personally find it very hard. Now, Reich's explanation for this had to do with, with armored character and so forth, and we don't need to go into that. But whatever the reason, I find it difficult to think functionally. But I think that if you want to approach this kind of problem, you really have to. Now, you can step back, however, I think, and you can ask some very practical clinical questions, which I believe Reich himself would have asked, and Harry, really did bring them up when he spoke before. And these are the ordinary clinical questions that we would ask. Question number one is, why would a therapist place a patient on medication? What is it in the clinical situation, in the therapy, that leads to that idea? It's not just well, it's partly that the medications exist, and we know that there are that people in orgone therapy, just like everybody, suffer from psychiatric symptoms and syndromes, depression, anxiety, and so forth. But there must be something in the clinical situation which leads us to recommend medication. Harry has patients, there's suffering, the therapy is proceeding in a certain way, and he feels that medication is going to be helpful. And he takes the steps to do it. And so we want to know why does the therapist do it, what's going on in the clinical situation, and then, of course, we want to know what's the result. And what's the result not only symptomatically, which any psychiatrist can predict, but we want to know what is the result functionally in terms of the orgone energy functions of the organism. So we want to know, and Harry also mentioned this, but I think we can break it down. We can ask very specific questions, like, what happens to the capacity for sexual excitation, for orgasm, for the movement of energy in the organism, the capacity for free pulsation of the organism. Is the emotional expression of the organism changed in any way? Is the configuration of the armoring, the segmental armoring, changed in any way, simply as a result of administering medication? Now, it seems to me that these should be empirically testable. But then we run into another problem, because part of Reich's functional view was a particular, I would say, a particular epistemological view, a particular view of reality, that reality is nothing more than the contact between a self-conscious organism and the energy around us. Right?
The environment.
Yeah. So, and I was thinking, I was going through a couple of character analysis and cancer biopsy in preparation for this, and I came across a wonderful anecdote which I've completely forgotten. It's been quite a number of years since I read the cancer biopsy, and most of it I had printed in my memory, but for some reason I had forgotten that there's this story in the cancer biopsy about dowsing. Now, in 39, whenever he wrote the cancer biopsy, dowsing probably wasn't
later.
40s. Dowsing wasn't that well known. But when I've spent quite a lot of time in Vermont, and up in northern Vermont, there's a center of dowsers, and people really believe in it. And when you want
I
to
use a dowser, actually,
yeah,
in Massachusetts to find a well.
When you want to dig a well in Vermont or Maine, you get a dowser. And everybody's kind of skeptical about it. Nobody really believes it. There's a certain awe, and Reich points out the mystical aspect of it.
Right.
That people see that the person is having some kind of mystical power. So Reich tried dowsing on his own, and he discovered that, in fact, if you had a freshly cut branch and you went around in a certain position, when you came over water, and he knew where the pipes were running. He knew where where the well was. That there would be an attraction of that branch to the solar plexus of the individual. He experienced it himself. And he had a theory about it, which may or may not be right, about the attraction of a larger, more higher energy system for a smaller one. Right, he conceptualized the water underground, the Earth itself, really, and the water as being an orgone system without a membrane, and he himself as being an orgone energy system with a membrane, and there was an attraction, and so...
It's like a doorbuster.
Well, whatever.
It became a...
Right, but my point is that other people couldn't do it. That the other, not all of his colleagues could feel it, and most of them not as strongly as he could. And I think there are other, if I'm not mistaken, there are other places in his work where he alludes to the fact that observation is dependent on the vitality of the energy field, which is making the observation, which is making the contact, even looking through a microscope. So probably looking through a microscope to see what Reich wanted to see is a function of the energy flow in the eye segment. Now Reich also had so this creates a problem because if Harry and I are the observers, not everybody in this room thinks that our energy fields are as vital as Reich's. Or as vital as we would like them to be. So, and if you're recommending, empirical research by lots of researchers, who
are they going to be?
Who are they going to be? What kind of observations are they going to make? So it's so that complicates things. Also, Reich's own understanding of neurological functioning was also very primitive. In the schizophrenic split, he puts down ideas which are highly speculative, and I don't think he wanted to give the impression that he was certain about anything, but highly speculative ideas about the brain being an organ which moves and which pulsates and which is capable of contraction, functional withdrawal of energy followed presumably by actual mechanical contraction. Now, these were totally speculative ideas, and it remains so to this day. So, because of all these complications, we have a problem in trying to understand exactly how medication would affect an organism. I wanted, there's one thing I wanted to quote from the Cancer Biopathy, because it's true, it's very hard in Reich's writings to find specific references to medication, but I found one. He's talking about his conception of cancer as a shrinking biopathy, as a function of the pulsation of the organism, and how the tumor is simply a local phenomenon, and that the phenomena which are more important are the anorgonia, the withdrawal of energy, and so forth. And then he talks in rather disparaging terms about the surgeon and the chemotherapist who want to medicate or cut. Not that he was against cutting.
No, cutting he was very...
Right. He was in favor of judicious surgery to get rid of the tumor mass. So he says, and it's a beautiful sentence because it's so terse, and the point is made without even saying it explicitly. He says, it would be simpler and more acceptable if a drug could be designed against the carcinoma, the shrinking process. Since this is not possible, and then I das. Now, it makes it clear, I think, that by simpler and more acceptable, Reich means, number one, it's not that simple. And number two, people are looking for quick cures, which they can't accept the fact that cancer might be related to something deep and something which has its roots in ultimately in society and in the way infants and children are brought up and in the way we manage our sexual economy and so forth. And since this is not possible, but see, it's a beautiful sentence, I think, because he's being ironical here. He says, as if the justification for using orgone therapy and for doing research like that on cancer was the fact that the other way doesn't work. That's not, of course, he's being ironical here. What he really means is that you can approach it locally by cutting out the tumor, you can give drugs to manipulate this, manipulate that, but that's not really what's at stake. What's at stake is a larger view of the organism. And that's the closest that I could find.
I think what's at stake for him, or in terms of his interest, is the broader view. Of course, for the patient, and that from what Sobi always said to me, Reich would always say, well, for the patient, if they have cancer, they want to get it, or if they have a headache, you want to get it treated as immediately as you can. But I think the separation here between what you do if you have a tumor yourself and what you do if you're trying to understand the full implications of it in terms of building a model, I think are very are crucially different.
And there isn't really much to go on in Reich's writings, I think, in trying to understand the relationship between the functioning of the orgonomic functioning of the organism on the one hand, and the chemical physical processes that we would ordinarily assume are affected by medication. I mean, all that there seems to be is a functional equation, which I don't think is very helpful. I mean, you have you have a functional identity between mind and body, between psyche and soma. So on the psychic side, you can work psychologically, you can do psychotherapy. On the somatic side, you can give medicine, you can do surgery, but then at the core, so to speak, or at the root of those two identical functions, you have something else, which is the biosystem. So I don't think that gives us specific guidance. I think one would have to get back into Reich's shoes, so to speak, and pursue the matter from a practical point of view and try to tease apart the practical and theoretical issues. Now, let me just end by saying that it's my personal view that using medication judiciously is not inimical to the progress of any therapy, orgone therapy or psychoanalytic therapy, which I also know about. And I'm not against it, and I don't personally think that it's to be avoided. On the contrary, I think there are situations where, for practical reasons, it should be considered and in some cases used. Just as an aside, there is an analogous historical development in the psychoanalytic movement, where for many years they were against using medication of any kind. And I believe that largely for economic and social reasons, because it was harder and harder for psychoanalysts to find patients who wanted to be analyzed and who were suitable for analysis, they started using medication. And recently there's been more or less a consensus, it's still controversial, that it's possible to use medication and do analytic work at the same time. Now, there are many, many important differences between analysis, the history of analysis and the history of orgone therapy, and one of them is that in psychoanalysis there is a long tradition of modifying the technique in order to allow it to be applied to patients who are not suitable for the so-called classical technique. And that goes back a long way. And the modifications are many, and it's not surprising that with the advent of these very useful medications who can stabilize very situations which otherwise are not workable, that psychoanalysts should have grasped onto this. But I don't know how far the analogy goes. I do think that it's justified. In my own experience with Harry, I haven't seen any cases where the use of medicine, if it's done judiciously, cannot be beneficial. I mean, you don't prescribe it indiscriminately. You don't prescribe it simply for the purpose of alleviating symptoms. You prescribe it with a view towards allowing the person to tolerate greater expansion and greater energy movement, and then that if and when that occurs, you can withdraw the medication, adjust the dose, and so forth. And I haven't seen in my, but I have to say that I haven't done systematic, bioenergetic examinations.
And also, this is no. I think we'll go to Dr. Schiff, his comments on this, but we should come back to this. The problem is we don't have a large systematic body of research and evidence. It remains again anecdotal. Dr. Schiff, in discussion with me, he'll maybe allude to this, in contact with Dr. Mushik in Frankfurt. Dr. Mushik raised the issue, which is interesting, of even beginning to look at the possibility that there might be medications, and Reich was aware of it. On some of the tapes of Reich talking and accounts of Sobey and Rothenberg also mentioned that Reich was aware that, there might be medications or substances or chemicals that actually enhance energetic flow. We didn't know. I mean, he simply, and one of the, just before we go to Dr. Schiff, one of the last things that Dr. Sobey told me about the use of the accumulator and the doorbuster was that what Reich said the problem was that you just, even with that, it got energy moving. It stirred things up, but it was very, very hard without long-term, broad, research to know exactly what the ramifications of that. And I think it's a similar kind of problem here. I think, again, coming back continuously to the fact that there are two issues. One, do we have the resources to even do research? And then if we did have the resources, do we have the individuals who are capable of doing the research at the levels on these CDs that Dr. Schiff and I have been reviewing, which have been very interesting, of Reich in seminar, he keeps reprimanding the other orgonomists present, the other people present, for the fact that they keep going ahead of the issue. They don't start with the fundamental issues of biological, that core, before you get to the functional identity of mind and body. And the core is always pulsation, energetic function, the unarmored organism, the unarmored substance. And that kind of research simply just doesn't really exist. But I think there is some very suggestive stuff, and certainly working with patients, observing individuals who are, not on medication versus periods of time when people are on medication and then off of medication. I think there's a lot of suggestive evidence that done judiciously and done effectively, a lot can be accomplished. Can it lead to, the question Dr. Sobey always raises, Reich would always say, does it establish the orgasm reflex? The answer to that is probably not, except for possibly ecstasy, which everyone is talking about now. There probably is no medication that does that. And certainly the illusion of Viagra doing that was a total illusion. So again, that is, I think, another part of this puzzle or this issue. But certainly, I don't think you can, out of hand, dismiss the use of these things just because there's some sort of dogmatic position against certain types of functions. No, we should go to Dr. Schiff, and then we'll take questions. Okay? Are you there? Still there?
I'm there. I'm
okay.
There. Okay.
Did you hear any of this?
What?
Did you hear any of this?
I heard it all.
Okay.
Very fascinating. And I, commend both you and Eric. I think you really covered all the bases. So what do I have to say then on the topic, seeing that all the bases were covered here? I just want to go over a few thoughts that I had, which are going to be within the context of what Harry and Eric said. Nothing new. In fact, pretty much the same, but maybe stated in a little different way. But I think addresses those central points. I wrote down a couple of central questions then in terms of this topic. First, I wanted to clarify the question, and I think Harry began to address that. What medications are we actually considering here? And as Harry pointed out, at first we thought about, or I was really addressing, because that's much more my experience, and sort of in terms of psychiatric psychotropic medications. But really, considering that orgone therapy is a therapy of the total pulsatory function, one would really want to encompass all types of medication in that arena. And personally, I have enough difficulty with the psychotropic medication in terms of my own experience and thinking. But that would be important. And then the second thing is, how do we define orgone treatment? And I think it's very important to have a kind of basic sense of what is orgone treatment, to be able to then kind of say, well, how do we use medications in orgone treatment? That brought me then to the second point, which again has been addressed, and that's that psychotropic pharmaceuticals play much of a role in both psychiatric and psychotherapeutic treatments. And I think, as Eric pointed out, even in contemporary psychoanalysis or psychoanalytic treatment, which has evolved a lot, there is the use now of and the appropriate use of psychiatric medications. As is really across the board in my own kind of general experience and, just a broad range of different psychotherapies, it's very rare to see really strong therapeutic approaches that are dogmatically opposed to the use of psychiatric medications. And clearly that's the case in the psychology community. So then I asked, well, what role do they play in orgone therapy, and why should their use in orgonomic treatment be different than that in the other therapies? What distinguishes orgone therapy, if we want to take issue to this, and some orgonomists do take issue to this in terms of, we really are, less prone to use medications than in other forms of psychotherapy because we are different in some way, shape, or form. How are we different? And how is this approach different? And what in that difference would lead one to take a different kind of attitude towards the judicious use of psychiatric medication than in most other treatment approaches? Again, these are just questions, and maybe questions to kind of further address. Now, the third question I thought of is something, again, that was pointed out. The goal of orgone therapy is to restore the patient to as close of natural bioenergetic pulsatory functioning as possible. Harry pointed that out. So the question is the use of psychotropic medications inherently antithetical to this process? Is there something in the use of medications that go against that restoration? And if not, and it isn't antithetical, is it drug specific? Meaning, does it depend on the nature of the specific drug? And if it does, are there some classifications of drugs that are more appropriate for use in orgonomic treatment than others? And I think this is what Harry was pointing out just a moment ago in terms of kind of a question in terms of, are there some medications that are more prone to promote bioenergetic expansion? Some are more contractive in their effects. But even if that's the case, which ones would seem to from a functional standpoint, be more in line with being more life positive than life negative? And again, that leads to the next question: how do we know that? Then do we really have enough knowledge in terms of our understanding of how drugs work? And I think Eric, pretty much gave the answer on that, and that's my understanding as well. We are just in our infancy in terms of understanding, both biological and neurobiological functioning, and some the nature. What's the word I'm looking for here? Exactly how medications work on the physiology and psychophysiology. The psychopharmacokinetics, I believe, is the word that I'm looking for. So we don't really know that. And so the question is that if we don't really know that, how do we then go about and make that determination? And I think Eric was speaking about that in terms of, well, we have to look in terms of both the practical, clinical side and the theoretical side, and this is the theoretical side. So one of the things I question, and when I think about this, is that do psychiatric medications directly act upon and affect the biophysical armoring? And if so, in what manner do they do so? Eric brought up a very important point, I believe, and in that, how do we determine that? Harry, I'm getting the feedback right now.
That's because David was. How's that, better?
Yeah, that's much better. No, it isn't better at all.
Yeah. How's that?
Are we back? No, it's worse now.
Sorry, I touched it. Wow.
We're hearing him fine.
We're hearing you fine.
I'm fine? Okay, so I'll tolerate it.
Is it your phone or?
No, I just started getting echo of myself.
Phil?
Enjoy it.
I'll manage. So going again, how do we understand the bio and psychophysiology of the armoring sufficiently to answer this question as well? So I think there's this whole other side to it as well. It's not only do I find that we don't understand how drugs really work, but do we really understand what is the biological nature of armoring? What is the physiology of armoring? And if we don't really understand that, how are we going to then kind of integrate our knowledge of use of drugs and, its effects upon armoring? So let me just give two more questions here, and then I just want to talk about my own personal experience with medications. So another question is that, and this is something that might be of interest to address, and maybe not, but as stated in the announcement of the symposium, many of those who are drawn to Reich's work have this anti-medication bias. I think that's exactly the case, and my question is, where does this stem from? And how accurately does it reflect Reich's viewpoints? I mean, I think we've gotten enough already this morning to really answer the second part of that. It doesn't seem, from my reading of Reich and from what Harry and Eric are saying, it doesn't seem to reflect Reich's viewpoints, either in terms of what he personally expressed or in terms of understanding of his theoretical position, I believe. So then it leads me to that first part of the question. Why has there been this anti-medication bias that seems to pervade at least some segment of those individuals who are interested in Reich's work and who practice therapy from his perspective? Okay, the last question is, in cases where psychiatric medication has been used in orgonomic treatment, what has been the clinical effect of medication on the process and course of treatment? And I think that's exactly, the final point that Eric was, addressing there. So given all of that, and I think we can talk, kind of address each of these in more detail in some way. I just want to speak about my own work as a psychologist, and orgone therapist, and my experience with psychiatric medications. And what I thought I'd do is I just went and I just kind of took I opened up my appointment book and saw, patients I see now and who of them are on medications and what has been my, just what comes to the top of my head about that. And so currently I have 8 patients who are on one or more of psychiatric medications. So 8, I think we're talking about an overall caseload, maybe a third to a quarter. So that's, so it makes me kind of question, well, is that typical of general psychotherapy practice, that there would be a third to a quarter, or is that lower, or is that higher?
I guess it would vary. You have to do a real
Practice.
It depends on the practice, but I would say certainly that's consistent. It's a little bit, well, it depends. I would say in my experience about a quarter, but I think there's some therapists who have all their patients on,
Right.
who don't see anybody that's not orgonomous. I mean, I think there is inherent, beyond the issue of the anti-medication bias among orgonomists, there is also inherent in the nature of doing orgonomy and why someone would come into orgonomy is to do it, is to do something that doesn't involve medication. I think, which is in a sense a bias, but not a negative bias. But so that when one, I think Dr. Weitzner is saying, when we do use medication, we use it in a somewhat different context or different way with a different overall goal and purpose. Many standard, psychotherapists, even working on some sort of analytic context, often see it as, at this point now, just part of the nature of the individual. They come in, they're on medication, they're in therapy.
That hasn't been my experience with, in general, and I do a lot of consulting also with psychologists, and with many of their cases, the goal is to use the medication as an adjunct until the underlying dynamic roots of the illness can be resolved.
Of course,
there's an analogy.
Well, of course, actually, Eric's consultations would be skewed because he would tend to work with people who had a more, functional view, even as non-orgonomous. I mean, in my experience, if you go to most clinics and agencies, you often see just the assumption that medication comes with, the territory. But I think
because it's a question of how deep you want to explore. Whether you're using a dynamic framework. Or
right. Yeah. That's what I'm saying is that. But anyway, I just think that probably we tend to have fewer patients on it, and we tend to keep them on far shorter periods of time as a general rule. But again, we don't really know this. I think what we're going to keep coming back to is that refrain that I always remember Michael Rothenberg saying, is that we just simply don't have a real, extensive research, and we don't have a kind of database that allows us to talk more broadly, and I think that's, whether that's ever going to be, changed, I don't know. I mean, I might be here 10, 20 years from now, if you like it, it's still saying the same thing. But I think this is the issue.
So going back, I think that's exactly the case. So going back, this percentage, and of this percentage, for most of them are on antidepressants. I think there is some lithium at times involved. One of the patients is on the Rontin, which is anti-seizure medication that's being now used for anxiety in small dosages. Let me see, of these 8 patients, 2 are in active orgonomic treatment, meaning that I am actively using biophysical work with really kind of the goal to really undo or break down a good percentage or some percentage of armoring to restore the patient to as much biophysical pulsation, pulsatory capacity, energetic flow as possible. 2 of those patients are in that. 2 or more in a supportive psychotherapeutic treatment, which I incorporate some of the biophysical approaches, and 4 are just in a purely verbal, character analytic or character-focused psychotherapy. And so that's currently right now, and essentially I don't find in any of these individuals, I have not found the medication to adversely affect their emotional or biophysical responses to treatment. And this is consistent with other patients I've had in the past. And again, it really, I think Eric said something that I'm always sitting with. I mean, who are the eyes and what are the eyes that are evaluating this? And, what is my own energetic contactfulness and my ability to read and feel energetic movement and pulsation for me to then make an evaluation that, hey, I have not seen an adverse effect. That's always something that I keep in mind. In fact, and contrary to the adverse effect, I've often found that these medications augment their energetic level, allowing for them to be more fully engaged in therapy. Constantly, or it's been said, well, medications will dull a person, they won't be even energetically alive, it'll bind their affect, dull their affect, bind their anxiety, there won't be enough energy there to move. But I'm not finding that, at least I'm not finding that in those individuals who are currently on medication, and I feel for maybe most of them, the medication, they're finding it effective, and it does seem to be effective in terms of their overall functioning. I've also found that that patients who don't seem to be affected or do well with medications, and it doesn't seem to enhance them in their treatment, they seem to know that pretty early on. And I've had a good number of patients, and this can be a very much a selection bias as well, and also my stance, which is not to really push it, who begin on some form of antidepressants, often is the case, or anti-anxiety medication, and just come away kind of feeling dulled, or their thinking is not helped, or they just don't feel as present, and they at some point they even more tend for themselves to take themselves off the medication, and oftentimes their experience is consistent with how I view them in the sessions. It's not always the case. So, in terms of, again, in terms of looking at patients' responses to these things, I cannot personally see, and often as I'm saying, I see the reverse. I cannot personally see how these medications are causing them to be more armored. Sometimes they seem actually pliably less armored, and that could be just the response to their feeling less anxious and less braced in the world, and then some of their surface holding and tension seems to diminish. Whether or not it's affecting them at a much deeper level, I cannot really say, but as it helps them engage in therapy more, and there's a capacity, it seems, with some of these medications, and I think Eric mentioned that when he said about how profoundly at times some patients just turn the corner and are living a very different kind of life as a result of antidepressant medications. The fact that they can be able to have much more emotional self-regulation and that they're not so flooded with anxiety. I see the same kind of thing in orgonomic treatment that is pretty much written about across the board, that patients can then engage in the therapeutic process in a much better way. The only medication, and maybe Eric can speak to this, that I found any kind of medications given for sleep, maybe the more barbiturate kind of medications. Those medications I do find have an adverse effect upon patients. And again, I've had a couple of clients with severe post-traumatic stress disorder where their sleep is profoundly disturbed. Some of them have to have been on some medication of this sort. But it does seem to dull. I mean, the after effects last, and I, depending upon when they use the medication, I do see that their ocular segment and their ability to engage and be emotionally present is severely, can be compromised. And how long-term that effect is, I don't know. Again, very little kind of just anecdotal kind of accounts there. So those are my overall impressions with this, and
Yeah, well,
I'm eager to kind of pursue these and deal with some questions here. Yeah.
to say the least, I think that certainly what keeps coming up for me is the theme of the fact that we, again, we can see, we can look, but even as Eric has pointed out, we don't even have available to us an ongoing careful monitoring of every patient who's on medication to see what kind of physiological readings we get, what changes, in the overall structure. And we're not also consistently starting with a database of what the orgonomic functional or the overall armoring of the individual is to begin with, because each individual presents different. It's not like you have everybody who has the same exact structure, and they're hitting the medication of the same dose, and you can do those kinds of controlled experiments. So we don't have the wherewithal to look at this. But I think anecdotally, and again, let me sort of put on the table here that anecdotal doesn't mean that it's not right or not useful or not scientific. It simply means that it doesn't have a broad, database. I mean, much of certainly some of the best science that's been done, including people like Darwin, worked anecdotally. I mean, to some extent. The question is whether you can build beyond simply anecdotal context to a broader understanding. The first thing I would like to throw out here, in terms of not just talking about psychotropic drugs or psychoactive drugs, is that one of the things that Dr. Sobey pointed out, which I have found to be consistently true and possible, Eric or you others can talk about, is that Dr. Sobey would say any medication that you ingest or take into your system has an energetic effect. So that and I've noticed this personally, if I've been on an antibiotic, I take an antibiotic, I get there might be other negative effects too, but my initial response is very energetic. I get an expansion.
That's opposite of what the drug does to your body.
Well, it doesn't. We don't know. And similarly, let me also add that we do not know what natural substances do. So people who say, well, I'm going to use garlic, I don't want to use antibiotic. Or I'm going to use with a similar thing with herbal treatments. Again, we really what an antibiotic does is certainly there are contractive functions to antibiotics that we know about physiologically, but that there is a boost energetically, experientially. Almost anybody who goes on an antibiotic knows that there is this initial energetic boost. Now, what that is. It can be theoretically discussed from a number of perspectives. What's going on, however, is that when you take a substance into your system, it interferes. There's interplay with the overall core of the pulsatory organism. What the full ramifications of that are can be complex. I mean, certainly with antibiotics, there's then a physiological equivalent to what we would call contraction or other kinds of physiological impairment of the organism as this goes on. I think part of keeping with the antibiotic psychotropic parallel is that what problem with antibiotics is somewhat the same problem with psychoactive drugs, is they flood the system. So that it's just really a basically scattergun kind of, the specificity of it, the narrowing of the focus of what you're shooting at, or the magic bullet aspect, is very, 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 very hit or miss. So it becomes harder and harder to predict. What it seems to me is the common functioning principle here is that all of these substances, whether it's aspirin or even placebos, impact on energetic pulsatory function in some way. And that's probably, if I were going to set up a research project to start studying and have the wherewithal, that would be what I would be interested in looking at, is the impact of a range of substances on overall pulsatory function. But there you'd have to start by getting very good readings of what that natural pulsatory function is, and then rating people's ability to function that way, which is what we do to some degree when we work individually with patients.
Harry, as you speak, what strikes me is that if one kind of looks at other systems, and I'm thinking mainly of Oriental medicine as a system of thought and a system of viewing illness, I mean, that is really so much their perspective. I mean, their perspective is to look at all substances and look at its effect upon the energetic functioning, and whether it's a yang food or a yin inducing, and then they try to combine and say, well, if a person has a certain kind of an energetic deficiency in one area, you would want to take this kind of food or this kind of herb because it has this effect upon the energetic system. They developed a pretty sophisticated kind of, I would say probably a database on many, many substances, not the antibiotics, I don't believe, but in many substances and naturally occurring substances, looking from that point of view. How one can correlate their very kind of sophisticated and complicated system with maybe the more basic kind of question that's being asked in terms of overall energetic pulsatory function, I'm not exactly sure. But there's such a long history of that kind of approach.
Yeah, I mean, again, I think, and that's a crucial thing. And the other thing is, again, coming back to how do patients, I mean, I think part of what you addressed out there, Dan, is in my experience, too, working with Eric on this, is most patients who don't do well on medications don't do well, notice it pretty quickly and can't tolerate it, whatever the medication, whether it's an antibiotic or an anti-psychotic. I mean, it's if they're not going to function on it, it comes up fairly within the early, The other thing is the vast majority, certainly in my experience, and that might be my orientation, is that most of my patients who are on medication have a strong desire to use it and get off of it.
Let me play devil's advocate for a minute. And I want to raise two questions about whether the use of medication might not have a negative side.
Mm-hmm.
I don't think that Reich wrote very much about depression or melancholia. I couldn't really find very much. I mean, and I'm sure that he had a lot of experience with it, but he didn't focus on it the way he did on schizophrenia and cancer as biopathic conditions. In one place, he does give the idea that an acute depression is a reflection of a sudden drop in the energy level of the organism. So I would raise the question, is it possible that an antidepressant medication raises the energy level back up to a more to a healthier level, and that would then enhance the treatment. But then on the other side, I would assume that if we would look dynamically and energetically at the structure of a melancholic or severe depressive state, we would discover that there is rage and hatred somewhere in the organism that cannot be expressed, which has somehow been on a dynamic level repressed, and in energetic terms somehow, I don't know how to describe it, withdrawn, the energy withdrawn, the capacity for its emotional expression, and that the incapacity for orgastic convulsion in such a case makes the rage and the hatred very intense. So I think the question has to be raised in a general sort of way, whether there's something, whether there is the danger of that being missed by having recourse to medication. The second question I would raise is that when you look at Reich's approach, I mean, he was not against the approach, the case-by-case approach, which we might call anecdotal, but he was very much interested in studying individual cases. But it's clear that when he found fundamental, deep disturbances of energy function, he wanted to address them as closely as possible to their root. And that's why he started using the Orgone accumulator. and he uses it, in that he describes its use in that case of this schizophrenic woman that he treated. That when he saw that she went into states of anorgonia, he put her in the accumulator, and he was able to achieve symptomatic relief and raise an energy level and some capacity for energy flow and so on. So my question would be, well, should orgone therapists not be looking for something with use of the accumulator or some other approach that would not be through the chemical route, but by stimulating in some more fundamental
I think absolutely.
flow of energy?
No, I think.
Has anyone ever used the accumulator in cases of depression?
Absolutely, I have. I mean, and I think, I know Dr. Sobey did. I think there are a number of issues here. One is, and using the doorbuster too, but the problem with, interestingly, and here I know that Reich talked about this at the end, the problem with many of these devices is that they work, again, it's similar to the statement that you, Eric, made at the beginning, which is that when you work with this enough, you see that it works. And anyone who's really worked with an accumulator or a doorbuster sees that, he both as a patient, and one of the things that Reich always insisted for therapists, and so I've had the doorbuster. It worked. Something happens. Now, the interesting thing you could say, it's just suggestive. I'll quote Reich to Sobey saying, so if it's suggestive and the suggestion works, obviously it works. I mean, the issue is what makes it work is a much, much more complex issue than the fact that if you work with this stuff on either side of it or with it, it works. It does something. And I use the doorbuster in my practice. I have it, at the office, and I can get results. But the problem is, as Dr. Sobey often pointed out when he had a much larger doorbuster, is you can't always. What you get is results. Something happens. There's obviously reaction. You can't necessarily. What we're limited in, and this is the complexity of it, is predicting exactly what the results are going to be or how.
But when it works, are the results sustained? Or can they be
Yes,
repeated?
I think they can. I mean, I have certainly treated, I can say without question, I've treated any number of people suffering from anxiety, depression, successfully without use of medication. In some, or the other reality being, I've treated many successfully with periodic interventions with medication also. So I think it's doable. I mean, interesting along those lines is the recent research that came out within the last 6 months, which is also, again, sort of just establishing what we've anecdotally known, but it's interesting, is that active physical exercise on a regular routine has an extremely positive impact on alleviating long-term chronic depression. Okay. As Dr. Sobey always used to say before the research came out, he said, "Yeah, well, you got to get the person to get out there and do it." I mean, that's the struggle to get. We've always known that activity engagement, produces very positive effects. But the point is, clearly, the core of this is energetic function, and I think what Eric is raising is absolutely true. What we shouldn't lose sight of the fact is that this is not about, when I conceived of having this topics was to sort of put it out on the table, was not to suggest that the answer is to incorporate or to translate medications or the use of chemicals into a way of revising orgonomy, but simply to face the real issue that medications do have a place and a function and do impact on the organism, and that it should be addressed and talked about, because if it's not, then it's done in ways that are not productive or in ways that are not understood. And I think we want to try to understand this more, so that as I understand Dr. Mushnick in Germany suggesting that we should begin to understand, are there medications that are useful, that are helpful at certain points? Are there medications that you should shy away from? and we're not putting out here either. We're talking about psychotropic medication. There are herbal remedies. That I think the raising of the issue of the Chinese medicine is very, very interesting in that you have thousands and thousands of years really to practice. And what happens when you talk to an herbalist, a Chinese doctor, is they specifically identify a specific issue and they target it with a specific herb that tends to impact only on that. They have a huge, huge array of experiential data on specific, symptoms, specific maladies that have specific things that they can hit it with. And interestingly, in Western medicine, we don't have that kind of specificity yet in most cases. There are a few medications, and certainly in the area of the neurosciences, in the discussion that Dr. Schiff gave about a year or so ago on just understanding how medications work from an orgonomic perspective. I mean, the key role here is that what most of these medications do is they flood the system.
The traditional Chinese doctors very often also recommend abstaining from sex.
Yeah, well, that's it. No, that's one particular. No, you should understand that's one. And if you read that carefully, I was interested in that. There's a sexual practice in Chinese medicine. One of the recommendations is during the period of use of herbal remedies to abstain from sex to build up larger, amounts of qi. So that the medications will work more effectively. On the other hand, in that Chinese medical practice, which is called the sexual path or whatever, they also then will recommend periods where you have very active sexual function. So,
mine was based on an anecdote of somebody who went to a Chinese doctor in Chinatown, and they have very flimsy barriers between patients. And she heard the doctor next door saying, "No sex, no sex."
Right.
So maybe he was right, in that case.
But they
have
obviously they have a very different apple.
No, anecdotally,
maybe they had an infection.
Can I jump in here for a second?
Well, someone else is making a comment there. If you just hold on one second.
Somebody told me when I first started treatment that I should abstain from any sexual activity for a day or two before my session.
Right.
And his reason was I would have less energy to work with in the session.
Yeah, but that's a
little similar.
Right.
No, I think
that's a rational, perfectly rational idea.
If I abstain, I'd have more sexual energy to work with.
Right. I think that's true. And there are some patients, you have to look at this also in terms of the functional reality. If I get a patient who is sexually promiscuous and active and every time they feel a little bit of tension or anxiety, go out and have a sexual encounter. Although in this day and age you find that less and less simply because people are more scared. But it's not without. I mean, I've had patients who I can think of a male patient who literally was picking up one or two women every day. I was amazed that. It was that, but he was very charming. I guess but the fact was, in order for therapy to proceed, I had to say you have to abstain. You have to stop having sex because the issue here is that the sexual acting out had nothing to do with the specifics of what we would call a healthy or orgastic potency. As Dr. Selby always liked to, he would say to a patient doing an intake, he'd say, "Well, how's your sex life?" And the patient would say, "Oh, great. How many times do you have sex?" "Oh, sometimes, with my partner, let's say your regular partner. How many times do you have sex in a night?" 5 or 6 times. And Dr. Selby would say, "We're treating impotency here." What? The reality was clearly, there was some, so again, it has a lot to do with our understanding. So when I was interested in that in Chinese medicine because there are 6 tracks of Chinese medicine. It's not just acupuncture, and one of them is the sexual sexual healing it translates into, and often they'll talk about abstention, but it's again very specific to what they see the nature. So it's an interesting, issue here. But again, if the issue is expansion and contraction and pulsation, I think again. I was just listening to these tapes of Reich talk, and what he keeps saying to the orgonomists at these conferences is you got to come back to the fundamental, basic core of the biological function of the organism. And I think then if you're going to look at medications and get away from the magic bullet premise, which is, I got this pain, doctor, make it go away, okay? And you say, okay, take these 2 pills and call me tomorrow morning. That kind of mechanism, which is understandable from my perspective as a patient. If I go to a doctor, I have a pain, I want him to make it go away. And if he offers me something, I'll take it, okay? That's different than trying to understand how and what these do in terms of maximizing our understanding of overall biological function and what improves the biological function, and how you're going to help a patient get to a point where they're functioning better so that they're doing less damage not only to themselves but in their environmental interactions, like child rearing. So if you get a patient who is, if a woman comes in, right, who is severely depressed, okay, has just had a child and is severely depressed and unable to breastfeed, right, and unable to be with her child, do you say, well, you're just going to have to persevere and suffer, or do you try to help her, and who are you helping if you don't intervene as best you can? You're not helping the child. I mean, the child is also suffering. So you have to look at these things on a broader scope. Very often, if I get a patient who comes into me initially and literally can't work, is losing their job, can't function, I can't be dogmatic, I can't be philosophical about it. I have to get them functioning to a point where the broader issues can be addressed. And I think that's something that often is not addressed in any kind of doctrinaire context. And I think, but what we don't want to lose sight of, I think, is that the goal in orgonomic work is to look at core biological pulsatory functions, and the goal remains always, does it enhance, or is it helping us towards the goal, not only as therapists but as patients, of healthier biological and ultimately orgasmic pulsation and function. And there's where I feel medications do have a role if used effectively, but again, we have a limited database on that.
Can I ask a question?
Let me just, can I jump in here?
Yeah, because you have to jump in verbally, so go ahead.
Okay, I just jumped in. There was the first part of that question, which is a very good, I think, very important 2-part question there, was the question of whether or not if the medication jacks up one's energy and then lifts some of the depression, will that then kind of mask what's needed then to be addressed, meaning the underlying rage or feelings that are really at the core of the depressive reaction. And I guess clinically, I guess it really depends, I think, on the experience and capacity of the therapist. I mean, in my experience, and this is my experience also as I get either more experience as a therapist, is that the medications, though they may leave or allow the initial presentation to change and the person to be better in life, that I find that seems to just kind of aid in them being able to mobilize those repressed affects that really have to come to the surface. And especially if the medications can relieve some of the anxiety, which then gives a much more chaotic presentation, and therefore it doesn't allow for those kind of deeper emotions to be really expressed.
That's a very important observation, and should be documented by case reports, just as a modest starting point.
Mm-hmm.
I just have a question. If you've ever
No, actually,
Yes.
Philip had a question first. So let me.
After about an hour. I remember Reich would reports doing the Reich blood test before and after someone would sit in the accumulator. And if this test is objective in any way, and I've never myself looked at blood, it seems to me that that's an entree point to all kinds of interesting
I agree.
empirical stuff. So, for example, in this room right now, there's a drug that would make me feel energized. I don't know if it would increase my energy, but it would certainly make me feel energized. I don't drink caffeine. So if I had a cup of coffee, I would feel much more expansive. Has that actually increased my energy? I don't know. I often feel expansive when I've had booze, but I think you wouldn't want to treat me after I've been drinking wine for a while. In fact,
Well,
you once told me I shouldn't drink wine before coming to see you.
No, you shouldn't drink or eat. I mean, you shouldn't really eat or really drink anything at least an hour or so before treatment. But because the digestive process basically slows energetic function. But more specifically, again, I think also we have to look at this, and I was struck by Dr. Schiff mentioning that, with some patients, which is true, you do largely character analytic work, and I think that very often the issue is, with many of my patients who are on long-term use of medication, where it's used more pervasively, often the real issues are not so much the specific physiological armoring, which are important. I mean, I'm not, but that there's long-term chronic characterological and structural issues, and in that case, in many instances, medications make work in that area much more feasible and much more structural. With some individuals where the characterological work has been done, or is largely not the issue, where you need very active physical access to the organism, then medications, I think, can be an impediment of any sort. There are times when I treat, I gave the example of, Dr. Sobey's using of aspirin. I've had patients who've had chronic migraines where I've been successful in treating the migraine by telling them, no, you come in, don't take any medication before you come in. We'll work actively without medication, and it can physically break, the migraine process. Dr. Schiff and I had talked about how at one point we thought it would be very interesting to set up an actual program to really look at, because this is interesting. One of the areas that orgonomy tends to have great success in, at least anecdotally, and again we have to look at this, is in the treatment of conditions like chronic migraine and asthma. I have treated 3 or 4 asthmatic patients who were severely asthmatic to the point where they no longer need or actively use medication, and occasionally, when they haven't been in treatment for an extended period of time. So I think there are times when that's again part of the complexity of being a practitioner, and I think that's true though for any kind of really good doctor. Is knowing when. Even my dentist, a lot of times will say, well, you don't need a shot. You don't need any, this can be done without it. You'll feel a little twinge, but it's nothing big. As opposed to, this is better, we better give you a light, anesthesia here to prevent severe pain. I mean, I think there has to be some active touch with who you're dealing with and what you're dealing with. But again, I really think it is an interesting thing that we do have available to us if we had the wherewithal to do research actively. We have techniques that even Reich has laid out that I think are available. One of them I think is absolutely right. Doing the blood work. I've looked at I've seen the difference between blood cells that have been irradiated in an accumulator versus those that aren't. I've looked at cancer cells, and it's visible, and I'm not a trained biologist or physiologist, it is visible, and I think you could see and look at and set these up. The question is having the wherewithal.
What I'm assuming that the word of depression is used in the society very loosely to cover what might be a lot of different conditions. But what would you say is the orgonomic definition of depression? Because if there is an orgonomic take on what's being labeled here, then it would seem to me to follow that there ought to be criteria to decide that this approach is more effective orgonomically than that approach. Yes, so if it's low energy, if that's a piece of it.
Well, I think Dr. Weitzner already addressed, to a large extent, I think it's a little more complicated than just simply saying that it's rage turned against the self. But essentially, when the energy moves back in on the organism, and is contained and moves from the periphery, and basically the organism begins to shut down, and has a broad physiological implications, and a range of those implications are what we would call clinical depression. But to go to a state of
Well, because of his focus on character structure, he didn't.
Right. Now, I mean, is that?
Well, it would seem to me if that's the definition, then that offers criteria for deciding that chemical X is or is not facilitating therapy. I mean, if chemical X is allowing the energy to be mobilized and to allow the client or the patient to get at whatever, or by contrast, if chemical X is inhibiting that process, we have a criteria that's usable.
I think to some extent, and we find anecdotally that that's the case. What we don't have, and I keep coming back to, is a broad examination of this to begin to build a fuller, more comprehensive. And if I had the power to set up such a research project, I'd also like to look at the non-pharmacological products, herbal products, other kinds.
Cocaine is also good.
That's absolutely. Like to look, Reich, interesting one, anecdotally, Reich was interested in the 50s, right, when the first research broke on LSD in the early 50s. Coming out of Sweden and Scandinavia, Reich was very interested in it. There was this Taj Philipson, had sent information about it, and thought it very interesting because clearly what happens with LSD, is this huge, dissolution of armor to a large extent, with an incredible rush of, and boost of energy. The problem was, and Reich read it, he said, and sometimes great orgasmic. Almost cosmic orgasmic experience. The problem was, again, it wasn't predictable. The initial interest in LSD was not as a recreational drug. It was initially, developed and looked at as a psychotropic therapeutic, and there were actual whole programs of therapy done with LSD. So the issue really is that, again, there's anecdotally, Reich was not opposed to looking at these things. So I think you're right. We have a context. How do we begin to organize? We need someone to come. If anyone has, a couple $1 million to set up a foundation, we'll get started. Let Bob finish make his statement and then go to Norm.
I said before, I heard Dr. Reich
say it loud so Norm.
I heard Dr. Reich say to his students, in fact, I don't remember the exact words, but in effect, don't negate, don't put down any other medical treatment until you can do better.
Right.
And I think that applies to this.
Right.
Because the object is to relieve and heal.
Right.
I was wondering about if you've had experience working with children, because I find in the school system so many kids are being given Ritalin, and it's I just see it's really used a lot. And at first I'm saying no, and then you say, well, yes, because some of these kids apparently were bouncing off the wall, but then you could see it almost being used. Well, in the case on Friday, punitively almost, to control a child who was coming from a horrible, horrible home. And the mother was going to kill him, so let's give him medication, so that he wouldn't explode. And I mean, where do you go with all of this?
Well, there's the reality. This is the frontline experience. I mean, clearly, I know that Eric and I talked about the use of medication with young children is problematic. One, because you're dealing with organisms that are physiologically developing. So the impact of many of these medications on young organisms is problematic. But then again, you also have to look at the overall reality of the child's life and the family life. In many cases, you're dealing with such situations that are so horrendous that nobody really wants to address. The real issue is that the child should not be in this environment and should not be, should not, but you do.
I'm not a child psychiatrist. I have some experience prescribing stimulants to adults who have been hyperactive children and who still have attentional disorders. And there's no question, these are not patients in orgone therapy, but I've helped people with these medicines. And I know that there are some children who are helped by them. I think conceptually, all of the problems are the same. But with the additional problem that it's a child and the central nervous system and the organism are still, developing rapidly, much more rapidly than in an adult. But I think conceptually it's the same problem.
It's the same problem.
I mean, you have a child who I mean, let's assume that people are correct when they say that there's some kind of neurological developmental problem, and that by flooding the central nervous system, with the drug, which increases the rate of neuronal firing, that you can help a child focus on a task. Now, in another society, it might not be important if the child at that age was able to focus on that particular task, but we have no control over that. So given the fact that our environment is the way it is, well, we have to make the kind of practical judgments that we've been talking about in relation to suffering in general.
Yeah, I think there are broad. I mean, this raises broad systemic issues that then get into what in orgonomic terms we start talking about mass psychological issues, which do you change this? It has a lot to do with coming right back to issues of child rearing, and then also how you approach this. Again, if you're talking about using medications at times with children, if a child has a severe infection, do you give them antibiotics? In some cases, absolutely. At other times, you don't want to. And I work with conventional pediatricians with my own daughter who say, no, all right, she's sick, just let it work out, because you don't want to flood the system. There's a tendency in the practice now with children to flood them with inappropriate uses of medication, but that's true across the board in the society. I think what Dr. Weitzner is saying is that it's not just with children, it's more horrendously catastrophic often with children because of the developmental issues, and also the fact that that society is tending to just abandon these kids.
There are also disadvantaged people in society for whom treatments are not available. And there are plenty of kids who were never offered Ritalin because they were poor, minority, whatever. There's that famous study in New Haven back in the 50s that showed that electroconvulsive therapy was almost exclusively a treatment of middle-class white depressives. And the poor black depressives were misdiagnosed as schizophrenic, given the wrong drug, or neglected altogether. So I think the social problems are huge, but there's something else.
Well, let me jump in here for a moment.
Yeah.
Yeah.
That's
I have two points to make on the Ritalin. I mean, one is that there are some interesting case studies in the journal Orgonomy. In fact, you can pull them off the web. I'm forgetting the name of the orgonomist who writes in terms of his treatment of, I guess, one or a number of so-called diagnosed ADHD children, and his effective use of orgone treatment without Ritalin. So that might be a kind of an interesting place to turn. The other point I want to make is this is something I remember Dr. Rothenberg speaking very strongly about, and he spent his whole career working with children as a pediatrician and psychiatrist, and he had very strong feelings about the misdiagnosis of ADHD or the lack of a comprehensive evaluation. And what he would often say is that, to really evaluate ADHD contains or needs more than just a teacher kind of saying there's a certain symptomatology and a pediatrician or someone needing to then quell that anxiety or whatever. It needs to be a comprehensive biopsychosocial evaluation. And under those terms, you can really evaluate, okay, which children really clinically need this kind of medication. It's very clear, and which children it's far more of a psychosocial issue, and the intervention should not be medication.
Yeah, the studies are fairly conclusive now. The new one just came out a couple of, I think, a month or so ago, that the over-prescription of psychoactive drugs to children as a way, and I personally have treated, I don't treat children actively anymore, but when I do treat children, I've treated children over the years where where parents have come to me and said, look, who have been in treatment, the school wants X child my child to be on medication because they're asking the wrong, they're doing this, or they're basically because they're a pain in the neck, right? And so when I've had what's happened is what we've had to do is then intervene to say you have to demonstrate that this child is clinically in need of this, or if what you're saying is this child is just a pain in the neck, or is asking too many questions, or not doing their homework, or that this does not necessarily mean that they're in need of active intervention. But the school's perspective is often like, hey, this kid's disruptive, this kid's giving me...
And the kid can be
right.
And there's the whole issue of contact, and contact between mother and child,
that's right.
Which has started, and how do you really,
And often the parent is coming and saying, I can't stand...
If the child's 8 or 11 or whatever, or
even
7,
younger. I just had a former patient who's out on the West Coast call me. She's had her baby, and she's doing pretty well, but the baby's a little colicky or whatever. It has gas, and she's saying she was just in a state. What can I do? Is there something I can do to fix this?
We're talking about children who really are bouncing off the walls, and are.
I'll quote A.S. Neal there. I think it's absolutely right. Is that there has never been a problem child, and I mean even a child bouncing off the wall who isn't, and the problem is today it's very unpopular to say, because the implication is you're blaming the parent. I'm not blaming the parent. I'm saying that even in a case of something like autism, you're often looking at, I was just reading a book on neurology, and the author was pointing out that it's very, very possible that, now that it's been popular to say, to abandon the idea that autism is the result of a cold, unacceptable, inapproachable mother. But what this neurologist was saying, well, what if this is the case? What if, and he didn't use the word energetically, but I think orgonomic is fascinating. What if the mother has biologically an autistic disorder to begin with, maybe not as operative as the child, and as a result of that is inaccessible and is cut off in some way, and the child who very possibly has some genetic predisposition interacts with that, and it begins to translate that way. We're just raising that question. So is that the cold mother? Maybe that is. The issue here is, from an orgonomic perspective, and that's what I always admired in Reich's work, is that it's not about blaming. It's about looking. It's like saying, I remember Dr. Sobel used to really laugh and say, everybody talks about AIDS, for instance, as if you're blaming the virus. It's like a bad virus. It's an evil bacteria that's gotten into your system. And Sobel used to laugh and say, that virus is like every other living organism. It just wants to find a nice, comfortable place to reproduce and sort of enjoy itself and live out its life in a good environment, in a good neighborhood. Its object is not to ravish, you or me or any. It's just that it's a question of which side of the organism you're on. If you're one of the viruses, it's a good location. If you're not, then you're in trouble. And I think that's the issue, is looking at, is, what happens is, I have a cousin who's a child psychiatrist, really on the front lines up in a major hospital above New Haven, dropped out of the hospital because what they were doing is essentially they were at this point already, he was seeing kids at 3 or 4 years old, who had already been on 4 or 5 major psychotropic drugs, and often they had 3 days in the hospital from admission, and the kid comes in beaten up by somebody in the family. They have 3 days in the hospital to make an active decision as for discharge, and so basically they don't know even what medications the kid has been on already, and he basically stopped practicing. He dropped out. He said it was like it was a nightmare. So that kind of thing I don't think is really that's of another order. I know that you, Allison Raden, that you work on the front lines in terms of these kinds of situations, and I think that's really of a different order in a sense, or not unrelated, than looking at whether if you did an appropriate evaluation, if you did look at these things, whether there are variety of interventions, even coming from what Bob just introduced on the table in terms of Reich's point. He used to say that, I remember Sobey said, Reich would say that, and I remember Dr. Rayfield at a presentation on the cancer work saying, you can't, unless you can offer an absolute alternative that's going to work, you don't, you do the best you can with what you got. Yeah, no.
Yeah, it seems to me that there's one point that maybe we covered it and I didn't hear it. But as opposed to an antibiotic, which does cure a disease, because it kills the offending bacteria, which is, by the way, probably why you feel good when you first start taking it, because the bacteria that's been making you feel rotten is dying. But after a while, other bacteria also die, and then you feel rotten again. The point is that the psychotropic drugs don't ever cure anything, because once you stop taking them, you're depressed again, or you're this again, or you're that again. The only thing that you can do with them is to continue to take them. So it's not a cure. I don't think anybody thinks of those drugs as a cure of anything, simply as something that. And in my own experience, I must say in my lifetime I've had a lot of exposure and close contact with people that take drugs, heroin, cocaine, marijuana, LSD, the whole business. And they appear very happy and very energetic often on the outside. But if you look at them closely, you don't get the feeling that you're going to get nice, intense personal contact with any one of them, or that any one of them really has the capacity to soar. And I would venture to guess that the same thing goes with people that are on psychotropic drugs. They may function, but are they going to soar in the appropriate times when they should? And I think that's...
that's an interesting... I'm going to jump in here. That's an interesting point. Those physicians who are more of the Eastern Oriental point of view would say, no, that antibiotics don't cure. That actually it hasn't really addressed the underlying energetic condition. And, in fact, the antibiotics weaken the system, which is being more clearly, I guess, kind of accepted, and, in fact, you're not really addressing a cure. And so maybe the analogy is closer to what psychotropic medications do. But I'm also wondering, maybe, Eric, you would know, has there been research with antidepressants in terms of a certain amount of use and then taking an individual off medications after a year? And has there been any kind of long-term follow-up on that?
Well, there are statistical studies about rates of relapse, which suggest that people with major depression always have some risk. It doesn't seem to be zero. But if you look at individual cases, there are people with chronic low-grade depression and especially milder kinds of major depression, which I believe can work psychotherapeutically, and why not orgone therapeutically, and will not need them indefinitely. That's my belief. I've seen some cases like that, but I can't.
But I
say any more
about
specific.
those drugs as an adjunct therapy.
Yes.
I'm talking about those drugs as a therapy.
No,
in itself.
I think that has to be put on the board. That the studies are where there is conclusive data and study, and the drug companies hate this, so do the HMOs, is that certainly in most disorders of the that relate to chronic depression of some sort, and certainly most of the disorders within the normal neurotic, what would ordinarily be called the neurotic sphere. When you get into issues of psychosis and other more profound pathologies, it's more debatable. But within disturbances within neurotic range, the optimal treatment, even in conventional terms, is always moderate use of medications, moderated use of medications with active psychotherapy.
Right. Of course, there's good evidence that cognitive therapy of depression is superior to medication in precisely that way, that you don't need to continue it.
Right.
So when you withdraw the medication, you have a high risk
So
of
it's an aid.
whereas cognitive therapy is a learning
Right.
technique which is incorporated into the way you think. But I think the fundamental question you're asking, I don't know that we know the answer to it. Whether there is some kind of inhibition that goes with the medication, or on the other hand, whether there might not be something tantamount to a cure. There are people who feel really well on antidepressants,
But they keep taking them.
and they keep taking them
But
forever.
they take them.
That's not a cure.
Well,
They keep
you
taking
don't
them.
call it a cure.
A cure would be if you can function without it.
Well,
Otherwise-
let's assume that you have. Let's assume that let's take something else from a physiological point of view. Let's assume that you have, I guess, diabetes. Diabetes would be. Now, do we have a cure for diabetes?
No, we do not.
But functionally, is the use of insulin or treatments that make you relatively, functionally no longer, actively at
Until you go
risk.
blind toward the end of your
Well,
life.
right.
You still have the disease.
So the issue is the question is whether, I remember Sophie actually addressing this too. We talked about. The question is there any cure? The reality is, the answer ultimately is no, because we're all going to die.
Being alive is a disease.
Right. So there is no cure. But if you're thinking in terms of getting rid of, the very issue that Dr. Schiff just brought up about, the use of antibiotics, is it a cure? Where you've gotten rid of that specific disease, but not necessarily.
It may not cure you, but it prevent you from dying.
Yeah, that's right.
It'll actually kill the disease. You may have
Kill the bacteria. Right.
The disease is gone.
I want to ask a question, but look, Norman, we're good friends, so I'm going to ask you that. I got a 60% blockage in one of my arteries, so I take cortisone, I take aspirin. It's kept me alive 10 years, and I'm very happy. I like it for another 10 years, okay? There's nothing shameful about that. If somebody has a depression, and they're not going to get a therapy that'll deal with it, or if the therapy can't get it resolved, there's nothing wrong with them taking it the rest of their lives. Forget it.
Wait a minute. I don't negate the necessity for you to take the medication. I think you should take it. I think you're right in taking it. But you can't say that it's curing your condition.
No, we're not.
That's my whole point. Once you can be cured of depression,
You don't cure you.
Well, the question, yeah, and that's right, and probably the most. I think what.
But if he had a drug which would clear his coronary completely, and so long as he stayed on it, his coronary arteries were completely open. That's pretty close to a cure.
Yeah.
look, if it's keeping him alive, I don't have anything.
Yeah,
I have
we're
no
not
objection to
supporting
it. But you can't say it's a cure until you can function on your own.
Right.
Totally.
Well,
Without any aid.
the issue really is, I think, really.
You eat all day. I mean, you eat every day to keep your body alive. You actually do things.
I don't
It's the
agree
same
that,
stuff.
Bob. I'm not arguing that point. That's not my point. You're right, and I agree with you.
Okay.
Yeah.
Okay.
The point is, you wouldn't suggest to someone that has a migraine headache that they should continue to take painkillers for the rest of their life.
No.
When maybe they can come in and have some
Right, no.
and get rid of it.
Okay.
And that's a cure.
Okay, right. That's right. That to the extent that we're looking, I think that goes back to what Bob quoted from Reich. To the extent that we're looking for a cure, there's a different standard that has to be applied. But in lieu of that, I mean, until that is available, then or in a sense, if we're, for instance, if I'm treating someone for depression long term, and I feel ultimately I can cure it, is it as an interim measure the use of an antidepressant to get to a stage where the cure becomes more and more available, an unreasonable course of treatment? That's basically what we've been addressing and talking. Okay.
And I just had a thought that, it's almost a philosophical question, like quality of life, and what do you, like I have 2 cats at home, maybe one of them is depressed, I would never know it, right? Because she just sleeps a lot. She doesn't eat that much. Then the other one's running around all the time. So,
One is depressed and one is overactive.
You got to get them Ritalin. There's an increased use of Prozac in animals, by the way. It's been a new veterinary use of.
Could I?
Yeah.
I think
And then we should really.
I think you got to distinguish, everybody, the difference between the HMOs and the medical schools and all the lazy people in the professions. Relying on this because it's a pain in the ass to treat people any other way. And also, there are only about, maybe in the whole country, maybe there are 100 doctors and therapists who can effectively deal with it.
No, I mean, I think there are broad, I think what this raises is broad, there are broad systemic social, cultural, behavioral, child-rearing issues, education, that are really, the kinds of things that we all struggle with. But I think what I was trying to at least put out on the table here today, and I think we did somewhat successfully, hopefully, is the fact that even in something like orgonomy, that is a specific type of treatment, that we have to consider the fact that you have this broad category of chemicals or substances that have some role or that are impacting, or at least at the beginning in infancy, understanding the nature and function of neurological function in ways that we should not just assume that we can dismiss, that we have to begin to understand, relate to our basic understanding, and begin to try to incorporate not only into our practice but into our analysis and our discussions. I think part of it is there's a tendency in orgonomy to say, I've known some orgonomists say, I can treat that, you don't need to do that, you don't need to do this. That kind of silvered attitude is that, you don't need aspirin, don't use aspirin. And I think that's a kind of dogmatic, philosophical, maniacal approach that prevents doing, effective care or understanding in care and treatment. And I just think that it's something that serious practitioners, I'm an orgonomist, Dr. Weitzner doesn't practice orgonomy, and Dr. Schiff does, but again, the kinds of collaboration and the need of understanding that. One of the things is that it might be important to begin to have more psychiatrists who are not necessarily orgonomists who understand some of what orgonomy has to offer as a total model, and might even also help. Whatever. I'm not getting into what, but it might even help in understanding the more effective use of psychotropic drugs. And so I think that's part of what is the next step, and possibly this will open up a dialogue. Well, unless there's any last questions, you have it? Yeah. What? Yeah.
Just as regards childhood. Medication use. It seems a particularly interesting area because Ritalin specifically, Dr. Weitzner can correct me if I'm wrong, traditionally, historically, hasn't that been used as an antidepressant in adults?
It's not very effective as an antidepressant,
but
as an adjunct to antidepressants or in elderly people who have very low energy levels. But it doesn't seem, from the studies that have been done, it doesn't seem very effective. Temporarily, it can make you feel great.
Right. Well, it's interesting because you're, even having had any history of being used as that somewhere, you're expecting sort of paradoxical results.
The results are definitely paradoxical, whether it's in a child or in an adult. When you give somebody a stimulant that in a normal person would make you more anxious, and the person suddenly calms down. On the other hand,